acidic environment. Hydroxychloroquine won't allow that acidification to occur. So they can't replicate if they can't replicate properly if they actually have this this hydroxychloroquine on board. There's massive amounts in the lungs, and it keeps the pH up a factor of 100. It's a massive amount, all right? So that they can't fold properly. So what ends up happening, here's the clincher. What ends up happening is the virus makes poor attenuated viral particles. It makes a few crummy viral particles. Does anybody know what makes up a vaccine? Attenuated viral particles, right? So hydroxychloroquine is like a vaccine for almost any RNA virus, including the flu, including virtually, rhinoviruses, all the coronaviruses. It's been proven to work against all the coronaviruses. So at the end of the day, the reason this eliminates the need for a lot of vaccines and a lot of antivirals. It's a big money maker to have antivirals. It's funny how our preventative health things now have turned into huge money makers. Vaccines, $16 billion given to some company to make a vaccine before they even made it. So this eliminates the need for a lot of that. Now I don't really care. You have to get smarter, sorry. We're gonna end up living here as, you have to come up with another, cure something else for us.
Right.
We already got a cure for this. We already have something, let me take the word cure back. We already have effective treatment, okay? So at the end of the day, that's how it works. It's basically acting vaccine-like. So you will end up with either very mild disease or very no disease, and you'll make virus. So they always do the PCR, all right, because you're going to find little particles. But you're coughing up a vaccine. If you cough on somebody, you're doing them a favor. So at the end of the day, that's that's the main reason this drug has been tortured. All right, but the data is overwhelming. It works extremely well, and the data is in the thousands of patients that have had effective treatment with it. So I really want to emphasize that. And does anybody know about PCR? Because we have a case-demic now. We don't have a pandemic anymore. We have a case-demic. Does anybody think we have a pandemic still going on? Okay, what's a case-demic? Exactly. So what we have now, they're doing these PCR tests, and what they do is they amplify the test. So you take a little piece and you keep amplifying it. And before you know, you're down to the base pairs is so small that you can identify that same matching base pair set sometimes on the human genome. For instance, there's some of that on chromosome 8 that matches perfectly with the genome of SARS-CoV-2. So, those PCR tests are legitimate, actually, to some extent, for actually identifying particles of the disease. And probably if they amplify it a factor of 20, then it's probably real disease. 30 maybe, and when you get to 40, which is what they're doing now in this case-demic, they're amplifying it to 40. And that means they've got trillions. So at 20, it's like millions. 30, it's like billions. Now they've got trillions of particles, basically, that they're looking at. And that amplification is allowing us to have this huge caseload of false positives, of people who actually aren't sick. They're actually, coming up positive. So it's a case-demic. And it's very nice to be able to tell you that, because we had a big spike in April, and then we had a smaller spike in July down here in Texas and Florida. And those patterns have come out in other areas, like in 1918, 1957, about 110 days apart. You'll see a big spike followed by a small spike, and that's the end of the pandemic. So what you're seeing is basically Redfield came out yesterday and said, you need to wear a mask, and yet you have one time, a couple of months before, they asked him in Congress, does any healthy person need to wear a mask? And he's a dry guy, he's just like, no. Yesterday, because he had to tell a lie, he basically had a joke like, well, yeah, this will protect you a lot like a vaccine. He's basically saying, vaccines aren't that great for an RNA virus, and this isn't that great either. Because RNA virus vaccines, they mutate all the time, right? So I hope we have a great vaccine that's well tested, safe, but the fact of the matter is vaccines have very ineffective against these RNA viruses because they're so mutatable. So when you do studies on them, as I'm doing passes in tissue culture, the virus is mutating. When I do the next study, a lot of times I've got a little different virus. So they're mutate a lot, and that's why it's going to be hard. So how does the influenza vaccine work? The southern hemisphere looks at the northern hemisphere's flu season and decides what to make their flu vaccine. And then the northern hemisphere then looks at the next southern hemisphere's flu season and decides what to use in their flu vaccine. So it's like a dog chasing its tail. We're always constantly chasing. And it's a good strategy, and it works anywhere from 4 to 50% of the time. It helps people. You see the statistics. 1% of people who get the flu vaccine will get the flu, and like 1.8% of the people who don't get the flu vaccine will get the flu. So it's almost twice as good, but 1%, 2%. It's not amazing. And that's what we're going to see with the SARS. So does anybody know about herd immunity? Are you interested in hearing about that at all?
Yes.
Okay. So we have, what we know about coronaviruses is this. It's a very simple thing. A lot of us have been exposed to coronaviruses for the cold. So there's 6 coronaviruses and now 7 with SARS-CoV-2. And what we found was with this virus, we have the ability to have cross-reactivity. So our T cells are very, very important. And up to 50% of us have very good T cell cross-reactivity, which means we're gonna be fine if we get exposed to SARS-CoV-2. It may, in some populations around the world, it's up to 80%. So we don't have to get to that far to go before we hit herd immunity. So what we're finding, and let me tell you the data, it's real simple. In New York, they got to 23%, the cases are almost zero. In Lombardy, they got to, I think, 18% cases are almost zero. Sweden, I think they got to 17%. So right around when you get to 20% of the population gets exposed, the immunity is in the population. And that's T cell immunity. That's the memory cells. Those are the ones that matter more than the B cells, which go away. Those are the ones we're testing. We're testing the B cells. That serology is testing the B cells, but that doesn't last. The T cells last. So we're in Houston area, we're probably at herd immunity right now, which means we're not going to get a lot of cases from here on in. So we're probably, we can open up our schools. And I want to, do you mind if I talk about schools a little bit? All right, because this is really important. Kids are not super spreaders. All right, they never have been for this particular disease. They can for some, but not for COVID. They haven't been. All around the world, for months, they didn't even have a child around the world that even passed away from it. Kids don't pass away from COVID-19 as much as they pass away from the flu. So the flu kills maybe almost 4 times as many kids as COVID-19. And the kids act like a sink. So if we said the smartest thing we could do is open up our schools, because the kids will get exposed to the virus, and they are not very good at transmitting the virus. They just don't get sick. They don't cough and spread germs, and they just don't get sick. So if we want to save our elderly, we need to let our kids go to school, because that's going to act like a sink, and that's going to allow us to develop that herd immunity in a much stronger way than if we allow So I got people, scientists over here. You guys want to hear those scientists? Yeah, that's pretty good. I'm sure they've read all the literature. No offense. Yeah, go ahead. Bring it up. So basically, with schools, they don't get sick. Okay. So if we want to have something, we should shut down every flu season. Okay? Because they get very sick from the flu. That's just the way it is. And so I'm not saying, like, they're not wrong what they're saying, but we should shut down every flu season. That's what that means, okay? Because they are right, some kids do get sick. I mean, there's no, you have to be realistic, it's gonna happen. But that means we should shut down every flu season. Does everybody want to shut down every flu season or not? Oh, that's what I thought, okay. So the data's not there. At the end of the day, the data's not there. And what's wonderful, the take-home point is this. We can help our elderly by opening our schools. We'll help our economy by opening up our schools. And when we do that, we can get back to normal. Not the new normal. So I want to reiterate that because it's so important to remember that. Take that home. Everybody who's here, take that home. If we allow our most healthy to absorb this virus, we spread the herd immunity, and it's basically like taking one for the team. You might get a little sick, but you're probably not going to die. Grandma's probably going to be much more likely to pass away. So by opening up the schools, we allow ourselves to be a stronger community all the way around. That's what this is. That's what happens with this disease. So I just have to laugh because it's the division that I'm talking about. Don't be mad at them, okay? Don't. All right? They're scared. It's okay. It's okay. All right? Don't be mad. Look, I'm serious about that. All right? They really are. I mean, they feel that way. It's the science is there, and if they would just look at it, that science is there. I didn't make this up. Kids are not super spreaders. Period. There's not one kid who spread it to an adult in the United States that they've shown. Period. Not one kid has spread it to an adult in the United States of America. Is anybody happy about that? And if they have evidence, and I'm welcoming them to bring evidence otherwise, it's not there. The evidence is not there. And we should welcome them because it's good. It's good to have people thinking differently because there's not one right thing in medicine. Everything in medicine, when I thought we were going to go through this, I thought we were going to put our heads together and work together, not apart and fight each other. We don't want to fight each other. We want to work with them. That's who we want to work with, them. Believe it or not, they're our community members. They're not our enemies. They're our friends. They're our family members. They are scared. And they have read stuff, and I understand why they're scared. I can read the data, okay? And that's the way it is. Sweden has opened up their schools, and they are down to 0. They are down to 0 cases, okay? So remember this one more time. If we open our schools, we're protecting our elderly. That's what you need to think, okay? We are protecting our elderly. Yes, I will.
Say it again.
So when we need a lot of people to get exposed to this virus. We need it. It's not going to go away if we don't have exposure because it's going to slowly make its way through. We're going to extend the whole time that the virus lasts. So if we allow our children who are much more adept at handling the virus to be exposed, they don't die from this disease like they do from the flu. It's like 4 times less. It's a significant number. So by allowing that to happen, we're protecting our elderly because the disease will burn out. That's how pandemics go. They burn out, and this is, you see, burned out in Sweden. It's burned out in Lombardy in Italy. It's burned out in New York because they have herd immunity. And that's the T cells. Those are long-lasting. Those T cells are long-lasting immunity. They're memory cells. Okay. I'm sorry? Well, honestly, his question was this. What was the biggest mistake we made? The biggest mistake we made was closing our schools and opening our nursing homes. How was that smart? The most susceptible. So what would have been the smart thing to do would have been, hey, let's protect our elderly. Let's prophylax with hydroxychloroquine. Let's protect the healthcare workers that are taking care of our elderly. And that would have been the smart thing to do. Now, I won't fault everybody for that. Not everybody's a scientist. Maybe some people at some point did it, they didn't know. But at some point now it's clear kids aren't super spreaders, okay? It's clear hydroxychloroquine is great at prophylaxis. It's clear that if we protect our elderly and prophylax people taking care of our elderly, we're gonna save them and they won't succumb to this disease. So, I think if you made a mistake in the past, I can look past it. When you keep making the same mistake, it's time to rise up and say, no, we're not going to take it anymore. And I'm totally serious about this because I have to deal with this with patients. Those people that are scared, they're angry, it's frightening, and I'm serious. Don't let them, first of all, stand up to them for the truth. Stand up for the truth. Never run from the truth. Which I tried to get that message to our president. Don't run from the truth. You guys know that I've been in and talked with Vice President Pence. I've been in and talked with Birx twice. I've been to Congress. I talked to senators. A lot of people on this COVID task force team I've spoken to, okay? And they're trying to do their best. They're hit with all kinds of information. They're not scientists. And then they get a tremendous lobbying from medical, pharmaceutical groups, and it's really tough. But the facts are the facts, all right? Hydroxychloroquine works, like I told you. It's been shown to work. All these major studies, Mount Sinai, Henry Ford, all of Belgium, all of Italy, all of Saudi Arabia, they publish all their data. It works. So, that's where we need to go with this. And I'll let you guys ask questions later on. I'm going to turn this over to my great friend. I met her through this crisis, Dr. Emanuel. First time I talked to her, I said, wow, she's something. She's amazing. And I called Simone Gold. Simone's been kind of a lead person in the frontline doctors. And I said, look, I've got somebody from Texas. She's treated a lot of patients. She's fabulous, I go. But Simone, I know you're sometimes like to have a controlling control what goes out in terms of information. I said, this woman has incredible charisma. She's knowledgeable, she's passionate, she's spiritually so close to the Lord. I go, if she comes, just let her do her thing. And she said, well, let me think about it. So she calls me back a couple of days later, I have to have her. I go, what happened? She goes, well, I saw her. I go, okay, well, just let her do what she does. She said she's amazing. So I'd like to introduce my great friend, Dr. Stella Emanuel. Thank you very much.
Hello, Columbus! Awesome. I'm just down the street in Katy. So I'm really excited to be here this morning. I hope all of you are excited to be here.
Yes.
Listen, I'm a child of God first.
Amen.
I'm a Christian. I'm a physician. And then I'm an American. I think I'm a Christian. No, I'm a Christian, I'm an American, and then I'm a physician. So, whatever I'm going to talk today is going to come from all those perspectives. I'm thankful for everyone that is here today, and a little background about myself. I'm a Cameroonian American, came to this country about 29 years ago. I went to medical school in Nigeria. I took care of patients with malaria. I'm kind of used to hydroxychloroquine. Chloroquine, we didn't have hydroxychloroquine. We had chloroquine, mefloquine, flavoquine, camoquine. And we actually took this medicine growing up, and we call it Sunday medicine. Everybody took it we all took it against malaria. Our parents used to make us take it every Sunday for prevention of malaria. So I grew up in this environment. I came to the United States, did a residency in Bronx, Lebanon Hospital in New York. I did general medicine back home, came here and I did a residency in pediatrics, but that was the first residency I could find. And when I got out of residency, I moved to Louisiana, Alexandria, opened a practice in pediatrics, and then I started working in the emergency room, walking clinics in the emergency room. I've done that on and off for years, so kind of kept my general practice. When I left from there, about 3 years ago, I kind of left clinic and just worked ER for a while. And then I came and opened a practice once I moved to Texas 5 years ago. I was going back and forth to Louisiana. Eventually got my Texas license a year ago and acquired a practice here and settled into being a general doctor and also doing a little bit of stuff that I would do in the emergency room in my clinic. Sutures, IV fluids, and little things, you know. So we were doing that, and then a good 15%, 20% of my patients come from the Middle East, China, Japan, all that area. Because the clinic I acquired, the doctor that was there prior was a Japanese, so we had a lot of Asian patients. So sometime in February, we heard about this pandemic. So you can imagine, I'm thinking about a bunch of patients coming in every day that are from the Middle East and Far East. And there is some disease that has come in from these areas. So of course, we got into serious PPE. We were dressed like space people from space. If you look at our earlier videos, we simply had the space suit, we had everything, the goggles, we got it going on, you know. We started seeing patients. And a friend called me and told me that hydroxychloroquine was being used for treatment. It's coming. We're getting data coming out of China, out of Europe, that they're using hydroxychloroquine. I was excited because these are medications that I'm used to. These are medications that I give patients when they're traveling to malaria endemic zones. So it was great. So, of course, being a physician, I looked up the dose for malaria, looked up the doses that were coming out of France and China, and then created a regimen, started treating patients. That is what I do. I'm a clinician. I know a lot of people tell me, Dr. Stella, you should be publishing data. I said, I'm a clinician, I'm not a researcher. My data is out there. Anybody that is interested, come and take it and publish it. We put it in a spreadsheet. But I really have not been able to come up for air, to breathe, to find time to put data together to publish, because it's been busy. My job is to take care of patients. We started taking care of patients, and it became so incredible because if a patient came in that had been sick for a day or two, and we put them on this medication, they got well like within 24, 48 hours. It was an amazing recovery. We've had patients get better, and I'm sure that there are people here that have treated